All right, so now we're moving on to our third disorder. All right, these are all neurodegenerative, multiple sclerosis. Okay, multiple sclerosis. So this is an autoimmune disease. All right, so the pathophysiology so far has been too little dopamine. All right, on one, and then on the other, we experienced with AD. It was a neurotransmitter issue also as well, but there was also a physical atrophy or loss of the anatomy, right? That's also causing that problem. With multiple sclerosis, it is an autoimmune issue, demyelinating. I'll show you a neuron in a second so that you can see what a myelin sheath looks like. But with this multiple sclerosis, there's an autoimmune issue. Let's see. No, I don't have it with me. I had a really nice description of the autoimmune. Did I put it somewhere? I might have put it somewhere. All right, but demyelating, that's the neuron has a long, neurons are long cells, and on those long cells are healthy myelin sheaths, all right? But with multiple sclerosis, we get this damaged myelin sheath, all right? And axons, all right, typically this part of a neuron cell, axons are typically wrapped in these sheaths, but there are gaps in them, and they're there for a reason. So a healthy neuron looks like one that has these gapped, healthy myelin sheaths, but when the sheaths are destroyed or damaged, right, we see multiple sclerosis, all right? And these episodes of demyelination, all right, because they do over time, there's regrowth and then there's episodes of damage again. You will see plaques in the white matter of the brain, and this is what causes the neurological deficits. All right, so the plaques that are created pretty much as waste products from the destruction of the myelin sheaths lead to the blockage of the conduction of the neuron's electrical currents, right? And you get neurological deficits. It's not really an electrical current, but it's like an electrical current in that each of those sheets are kind of sending a message to the other, and it's conducting that message. Probably could be anything from brain telling kidney that there's too little, you know, there's too little water in the body and that we need to hold on to more urine or more water. Okay. So it could be anything. But that said, it's the sheath or the demyelination that makes it multiple sclerosis. All right. The course to multiple sclerosis is not exactly, it's progressive, but there's this like relapsing and remitting course, right? There's an eventual progression to the most progressive form, but it kind of starts off a bit uh, progressive, but there will be relapses or periods where things get better. Okay. And what are the symptoms, right? You might see cognitive issues show up where the person's just not thinking correctly, like cog fog, right? A cognitive fog. There could be lack of coordination because there are vestibular cochlear nerves that are being affected. And so they experience vertigo, which is like when the room is moving around you and you can't like find a stability or a stable position in the moment. So you almost feel nauseous, like you're doing loop-de-loops. All right. You may get what we call when you have tingling and numbness in the extremities, we call that paresthesias. Paresthesias. And paresthesias can occur on some part of the hand, a part, maybe one half and not the other, because again, the nerves are trying to send messages to their target organs, and sometimes the message is missed. Okay. Slurred speech, blurred vision. Okay. You notice with these cholinergic or neurological, neuromuscular or neurodegenerative diseases, we're seeing some of the same types of symptomology. Slurred speech, blurry vision, we saw in Parkinson's as well. Well, we didn't see blurry vision as much as we saw the forced closure of the eyelids. All right. And then bowel issues, bowel bladder functions, you should also always think autonomic. That's not necessarily a motor neuron, that's an autonomic neuron doing something there. Okay, so it starts getting you to thinking about what the therapies might be. All right, so the normal nerve, right? You have the body, the nucleus, so the main part of the nerve body with some dendrites coming from them. And then that long part of the axon that's going down to send that message from brain or wherever the nucleus is down to the terminal parts, right? And it's all about the sheath. Everything else looks fairly normal here, but it's the sheath that's destroyed, the myelin junctions on the sheath in multiple sclerosis. This is a disease that affects women a bit more than men. So our model here is a woman, and again, the changes as described before. There is a heat sensitivity a matter of not being able to really, with those paresthesias, perceive touch or sensation as you would if you were healthy. All right, so risk factors. There is a genetic component here, the HLA-DR2 allele on the genetic, on our genetic, how we've mapped out the genome and we kind of know where things are and how to identify them. All right. Now, do we have, again, targeted therapies, genetic therapies for this yet? No, we don't. I wonder sometimes like what will happen if we get all the genetic solutions to the like the problems that we have. Like who gets affected the most? Like will it be like big companies or I don't know, big pharma, or will it be a whole new industry that arises? I don't know, but we know where it is now. We just have to get on figuring out how to treat this in a way that improves patients' lives. There's a higher prevalence in females and people of Northern European descent, thus kind of giving us a clue that there's some genetic susceptibilities there. All right. Now this one, MS actually accepts or acknowledges that the Epstein-Barr virus may contribute to its etiology, Epstein-Barr, but they won't do that for Parkinson's disease, which I think is interesting. But here's an example of how a virus and the long-term impact of that virus could actually create a neurodegenerative disease. Okay, smoking is affected smoking is impacting MS. All right, vitamin D deficiency as well. Now, how does it show up? Optic neuritis, where there is some vision issue there. Okay, muscle weakness, spasticity. Now, what's the difference between spasticity and rigidity? Like a muscle can be rigid, but a muscle can also be spastic. What do you think a spastic muscle? No. See, so rigid for sure, like might be in one position, hardened almost. Whereas spastic might be like what kind of? Yeah, absolutely. Yeah. So whereas spastic might be like, I'm kind of stuck like this, and I mean not spastic, but rigid might be like I'm kind of my arms are stuck like this, and or I'm otherwise just kind of making these rigid, right? Whereas spastic might be like, you know, like an involuntary movement that is kind of like off, and it's spastic meaning like, someone might say like he's spazzing out, it's almost like uh um it's kind of uncoordinated. It's not purposeful. It's just kind of like the inability to really control that. Okay, so spasticity is a part of that. Paresthesias, as I mentioned before, would be the partial like loss of sensation. Usually aesthesias refer to the sensation. All right. Fatigue is huge in people with MS. I mean, crazy fatigue. I mean, it's not like, and what is fatigue versus tired? What's the difference between someone who's tired, which we all are in here, versus fatigue? If someone was in here fatigued, how would we know it? Like you're suffering from fatigue and not just tired. We have a main way in nursing that we count fatigue versus tired. A question we can give that'll let us know, oh, they're probably really fatigued. It has to do with sleep and what happens when you sleep. So if you have fatigue, you go to sleep, you wake up, you're still tired, right? But those of us who are tired, if we can have a nice long weekend, right? We feel like we might be able to catch up on a little sleep, right? And feel refreshed, perhaps after, a vacation or 2 or 3 days of rest. Folks with fatigue, no matter what or how many hours of sleep they get, they're going to wake up and still feel bushed, like absolutely drained. All right. So that level of fatigue is what MS is all about. And when I think about MS or multiple sclerosis, I'm often thinking of a person who is experiencing so much fatigue that they need a wheelchair. All right. That level of fatigue. All right. You might also see bladder dysfunction. Makes sense if you have those myelinated sheaths that are doing all kinds of autonomic and motor functions, and you lose that, or you lose that myelin sheath protection, that you might actually experience dysfunction. All right, so the types of multiple sclerosis have to do with the episodes of relapse and gradual deterioration. All right, so when it's relapse remitting, that form, you get episodes of neurologic dysfunction with full or partial recovery. So if you've ever known anyone with MS, you might know that at some point they weren't in that wheelchair, or at some point they were in the wheelchair and then afterwards you saw them walking again, right? So you thought, what's going on? They might have had a relapsing remitting episode where they had an episode where they absolutely were completely fatigued. They had very poor function. They were losing their bladder function. The sheaths were not sheathing, okay? And as a result, they end up with this dysfunction. But then there's regrowth of the sheaths and they're back to functioning at a full functional level. All right. MS is tough. It's hard for people to understand what's happening if you have a parent or a loved one with MS, because sometimes they seem beautifully perfect, and then other times you're like, how did you get this way? What happened? Okay. So there are these episodes. Now, at some point, you go from the relapsing remitting version to the secondary progressive version, where now there's this gradual deterioration, whether or not you have a relapse. All right, so you could have a relapse where things just go completely dysfunctional, right? But when you come back, you only have a partial recovery, right? Now you're in that secondary progressive phase, right? And then there's this primary progressive phase where it's just a steadily decline from the onset, where this person who has this type of multiple sclerosis will not see full or partial recoveries. Things just get bad and they get worse and they keep going bad. And then they have these superimposed attacks where things continue to decline. Okay, so it's progressive and it doesn't get better. All right, so because this is an immune or an autoimmune issue, our target therapies are going to be immunomodulatory. So they're going to do things to modulate or the immune system cells. All right, so these are very interesting and creative therapies, and we'll talk about them. They're the injectables, right? The injectable interferons. Interferon is amazing. To find an interferon that might work with MS is a real game changer for them, I'm sure. Injectable interferons, probably super expensive though. We'll talk about it in a second. Glatiramer acetate, another very unique drug. And then you have the oral agents. So those are the injectables. Then you have the oral agents that I'll show you in a second. And then finally, the monoclonal antibodies. Because this is an immune system issue, we have far more therapies than we have for those that are like issues of the brain matter. Okay, so we have more therapies that are tolerated better. And we have the privilege or the ability to tailor them because we have so many types of therapies. So this is a good thing for MS folks. All right, so you can do the interferon beta. That's an injectable. It literally reduces T cell migration across the blood-brain barrier, which is amazing, right? And it just sounds and looks so expensive when I see that. right? Anytime I see interferon, I'm just thinking inject it weekly or several times weekly. Yeah, if you can afford that, that's really a great idea. T cell migration. So T cells, all of the immune cells go to the thymus to get their instructions, to learn which immune cell they will become. So they're these pluripotent cells that are pretty much capable of being any kind of cell. They go into the thymus though, and they get their orders, their marching orders. And you are going to be a certain type of cell, right? So the thymus is where like the control center of all immune cells. So I'll talk about how we might address this if we can't use these great injectables or some of these other good therapies. All right, glatiramer acetate. It kind of looks like myelin. It's a decoy. So it gets into the body and it acts as if it is able to coat the axon body of the nerve cell. All right, it sounds amazing, except that it will cause a patient to feel like they're having an ischemic attack, a heart attack. Okay, chest tightness, palpitations will have a person thinking that they need to go to the ED because they absolutely are having a heart attack. And if they're on this medication, you can educate them and tell them that it's disturbing, but it is expected and normal, and that we're going to get you through this. Okay. All right, so we have a little practice question here. A patient is starting interferon beta 1B and says, this will cure my MS. Correct their misunderstanding. What's the correct teaching there? Maybe guessing a little bit with that one. Interferon beta 1B will cure my MS, they're hoping. I did get really excited about it, said it was a nice expensive drug, right? But cure my MS? No. What's likely happening here with this drug? Yeah, absolutely. Right? So we're here to help, but we're not going to cure this. Okay. A lot of these degenerative disorders get bad because we don't have a cure. Okay. All right. We may still want to just work with this person to understand the educational pieces that we do want them to know, their injection technique. All right. The fact that they are going to probably have flu-like side effects. Okay. And that they can take Tylenol or acetaminophen for this. All right. Injection techniques are going to be important in these injectables as well because they have to meticulously rotate their sites, not like with insulin and with a person who's diabetic. Yeah, you can rotate your sites, makes sense, right? You don't want the little lipid things to form. But with these injectables, you really have to think about the last place you injected it because you're going to inject it in a different place the next time. All right. Interferon beta 1B has that as an educational point. All right. Moving on to the oral agents. Fingolimod. All right, this is one of the oral medications for MS, and we want to monitor the heart rate. I tried to highlight monitor the heart rate in all of these because that's what I want you to walk away with, understanding that the heart rate, the cardiometabolic risks need to be managed with these oral MS drugs, okay? The other important factors are there for you, but I want you to see the theme, okay? There's a second line oral agent called cladribine, and this one does not come with the serious cardiac concerns, okay? But we do need blood tests because it's an autoimmune issue. We are going to want to see how these adverse effects impact their CBC results. Okay, there are just more here, the ones that end in Zumab. All right, that's kind of how you know it's an immune drug, right? A lot of the immune system drugs, autoimmune drugs, end in Zumab. All right. Monoclonal antibodies and infusion treatments are listed here. Monoclonal antibodies are great too. They're kind of expensive and fancy like the interferon B drugs, but they're a little bit more targeted and tailored. All right. Monoclonal antibodies are where you take an antibody and you clone it, one antibody, and you clone it over and over again to create pretty much like a vaccine for your problem. All right. So it blocks immune cells moving across the blood-brain barrier and decreases relapse in that way. Okay, so we're trying to treat these MS relapses the best way we can, whether we're using the monoclonal infusion therapies or the oral agents or even the interferon beta and glatiramer. Whether we use any of those therapies, we're absolutely going to want to be addressing the fatigue and the relapse. All right, so how do we manage fatigue? We have to teach them how to conserve their energy, to schedule rest periods, all right, and different measures for just cooling down, okay? That's really what we're doing. Now, there's also for fatigue, amantadine and modafinil to help reduce fatigue, but those aren't as important drugs to remember as the main MS drugs. All right, and then maybe we can help them with their cog fog or their cognitive fog by helping support their concentration difficulties. There's cognitive rehab out there. Usually it looks like they're doing puzzles, but they're really working very strategically to help that person retain as much of their cognitive ability as possible. All right, so we have another case study question. We got a patient with RRMS, okay? RRMS is relapsing remitting multiple sclerosis, so where they have episodes of neurologic dysfunction with full or partial recovery, okay? That's the version that they have. And the question is asking, all right, the patient with RRMS has been on interferon beta for 2 months and reports flu-like symptoms and injection site redness. All right, so what are we going to ask them? What can we do for them? What should we do? 2 months, and we've got flu-like symptoms and injection site redness. Do you think they're going to be taken off the drug? Do you think the drug is going to be adjusted in a way? Do you think you can help them with the side effects? What do we do in your scope? Yes. Okay, what can we give a person experiencing flu-like symptoms? Because remember, flu is a virus, so we can't really cure it or anything. We can just treat the symptoms that come up. What are we usually going to treat that with? Yeah. Motrin. Yeah. Tylenol, Motrin. Yes, sounds good. What was that? Or rotate the site, okay, for the redness. All right, because remember, we want to meticulously rotate the sites. Excellent. All right, so we give them some NSAIDs, maybe some Tylenol, and we rotate the site, okay? Oh, I meant to put the question up there. Pre-medicate, okay? Pre-medicate, and that can help with the flu-like symptoms because it's the medication that's causing the symptoms, all right? So we can pre-medicate. Rotate the sites. We can use ice packs as well. Ice packs might help that redness. Yes. So the sites are kind of like the insulin sites. Yeah, you just need to be meticulous about them. So you can't forget that yesterday you were on the same side because the negative outcome will be worse than what you would see with insulin. All right, so it's wherever you're going to inject it, don't inject it there again the next time. All right, that'll be key because they definitely cause. They're just kind of a stinker in terms of being an injection that causes problems. All right, so we're on our 4th disorder, and it is myasthenia gravis. Okay, I offer this graphic because it's something I want you to know about myasthenia gravis, and I want you to continue to make this connection. What do you think this is pointing to for anybody who might have pre-read or What is this one eye doing? Drooping, yeah. And what's that called? Does anybody remember what it's called when you have a drooping eye? It's one of those really like fun words that you could never really figure out on its own. Starts with a P, ends in an S. Right? Weird, right? Ptosis. Yeah, ptosis. It's like a drooping eye. All right. There's also the possibility for diplopia. Do y'all remember that word and what that's all about? Diplopia. What's that? That's nystagmus. Yeah. Diplopia, diplopia, diplopia. Okay, DI means two as a prefix. Double vision. Yes, double vision. So a person with myasthenia gravis might have double vision, they might have ptosis. And those are two cardinal signs that they are dealing with MG or myasthenia gravis. It is another autoimmune issue, but this time we're attacking the nicotinic acetylcholine receptors, the nicotinic ones. Muscarinic is what they're called, at the neuromuscular junction. So if you have a receptor that lives at the junction of the neuron and the muscle, because neurons are really long and they go all the way to the target organ, in this case is to muscle. So you got a neuron that started in the brain, it's super long, it went all the way down to the destination muscle. That means if you're going to have a medication act at that site, then it's probably going to impact muscle movement. Okay. And hopefully a good medication that's working like it should allow us to improve muscle movement. Okay. Now, sometimes our muscles are smooth and involuntary. Other times our muscles are voluntary muscles that we can make do what we want to do, right? The blinking of the eye, not so voluntary. We can do voluntary movements with the eye, but some of those blinks that are happening are involuntary, for example. All right. So with myasthenia gravis, you might see in the pathophysiology ocular and bulbar symptoms. Ocular being those related to the eye. We already talked about ptosis and diplopia. And then bulbar, those that are related to, how do I want to say this? I had a good word for it, and I want to use that, and I don't want to go back to but time is of the essence, so I'll come back to you. Here are the words that describe it. What's dysphagia? Difficulty swallowing. What's dysarthria? Articulating is good, but it's actually about the joints. Arthritis, arthria, that's the root word for that. So dysarthria, some dysfunction in the joints. All right. So the dysphagia and the dysarthria have to do with the muscles, right, that the neuron is talking to. All right. So if we have some kind of malfunction in the joints meet the muscles, right, in different areas, or some type of issue with the swallowing, which again is about muscle movement, involuntary muscle movement. All right. Then that's going to explain some of the symptoms that we see in the myasthenia gravis patient. All right, we might see proximal limb weakness. So whereas the proximal limbs might have the weakness and atrophy, the patient with on the distal limbs, they may look more normal and less atrophied. Okay, I think I do have a picture of someone with myasthenia gravis to indicate that the issues are more proximal than distal. Okay. And with that proximal weakness, we might see respiratory issues as we are thinking about the diaphragm and its involuntary or autonomic movements, right? And if the diaphragm becomes fatigued or weak, all right, we can have a respiratory risk because diaphragm is not elevating and lowering as it should. All right, so with myasthenia gravis, things get worse with exertion and improve with rest. Again, worse with exertion, improve with rest. I'll give you an example in a second. And they fluctuate over the day. All right, so you might have a person, if your partner has MG, right? You might wake up in the morning with them and they are in a certain like presentation, right? But over the course of the day, they might begin to experience ptosis, diplopia, the dysphagia, and dysarthria. All right. So there is a fluctuation that happens over the course of the day that worsens with exertion and improves with rest. So one of the ways we diagnose it are to look at the antibodies. All right. So if it's an autoimmune system, there should be some antibodies to indicate that you have antibodies present, right? You'll see those. That's one way to diagnose. You can also diagnose with this thing called the bedside ice pack test. This is where you take that eye that has the drooping and you put an ice pack over it. If it gets considerably better after 10 minutes of sitting under that ice pack, if the drooping is considerably resolved, probably myasthenia gravis. All right. But if it stays, could be something else, right? Could be a nerve issue, could be a stroke, could be Alzheimer's or Parkinson's, right? But in the case of myasthenia gravis, there's a fluctuation that happens. So the bedside ice pack test is one way to know that the resolution of the issue, the temporary resolution of it, indicates that myasthenia gravis profile. All right. So we're basically looking at the patient's ability to manage their fatigue or how much capacity they have to get through their day as the risk for crisis, right? If a person still has a lot of function, right? But if their symptoms are worsening over time and with exertion, they need to begin the treatment therapies. All right, I know I pulled this from something that has gobbledygook here. It doesn't make sense, but I really wanted to pull in on the neuron, right? And receptors and how a nerve cell has neurotransmitters that release into the gap, right? Where the receptors are. And a lot of times with these drugs that we're using, we're trying to get the nerve to produce more of the receptor that we want or to block the signal of the receptor. In the case of the medications for myasthenia gravis or for the condition myasthenia gravis, the nerve cell, which is providing the little red dots or acetylcholine, are blocked by these little Y-shaped blue blocks, blockage, blocked signals, okay? And then the receptor is therefore blocked and the signal does not arrive to the muscle, all right? So you get the weakness, you get the ptosis, you get the double vision, all right? All right, so that's what I wanted to show in that slide. All right, so what do we do to treat these presentations, right? It's autoimmune disease, so we got to think immune system. All right, so the cholinesterase inhibitor, we start there. You've heard this before, the cholinesterase inhibitor. You've heard that before because we give that to the our PD people as well. Oh no, cholinesterase inhibitors we were giving to our Alzheimer's folks. All right, so pyridostigmine, if it ends in stigmine, it is a cholinesterase inhibitor. It is the first line of defense or the first line treatment therapy for myasthenia gravis, all right, and it's to control the symptoms. So what we do is we time the doses to the meals so that we can improve or enhance the patient's ability to chew or swallow, all right? So if we give the doses at a time where they're struggling with and having dysphagia, that's not good. Okay, so what we want to do is to give the medication 30 minutes before the meal so that when it comes time to eat, they can eat with less dysphagia. Okay, it literally impacts the muscles, this medication. All right, some of the adverse reactions of drugs that impact the muscarinic receptors are SLUDGE. SLUDGE. SLUDGE stands for salivation, lacrimation. What's lacrimation? Tears, right? Yeah, everybody pointed to their eyes. All right, lacrimation, tears. So lacrimation is like nonstop tears. Like my husband has that, where he goes outside and is certain pathogens in the environment, He's just looks like he's crying his eyes out. And to be honest, he never cries. So I'm always like, oh, and he's like, anyway, lacrimation. We've been married 25 years, and I've never really seen him like cry. So it's funny that that's the way he gets his tears out, his allergies. All right. So that said, sludge, salivation, lacrimation, urination, okay, diarrhea, GI cramps. I like to think of sludge as like when you're talking about the muscarinic receptors as like wet. Salivation, lacrimation, urination, diarrhea, GI cramps. All right. Whereas you have those drying effects of the cholinergic reactions that can be like constipation, dry mouth, like you have the drying, the anticholinergic stuff. So this sludge adverse effects, I like to think of them as wet, like the wet stuff. All right. Plus we get the bradycardia, the nicotinic receptor issues usually are muscle cramps or the twitching of the muscle involuntarily. Okay, so those are adverse, meaning we do not want these reactions, despite the fact that these are the first line drugs. So whenever you see adverse reactions, we want patients to report that to us. All right, immunotherapy for control. So we give them steroids. That's immunotherapy around steroids, or usually corticosteroids, are that they support you while you're going through a disease process or some type of exacerbation. All right, those are the main ones. And biologics are like these almost like chemotherapy drugs that we'll talk about when we get to chemotherapies next week. All right, but again, that's a pretty tight treatment regimen for myasthenia gravis. And if all else fails, we can do a thymectomy. All right. So I talked about how the thymus is the place where all the white blood cells or cells of the immune system get their orders, their designations. All right. If we take the whole thing out, all right, then we can reduce symptoms. All right. That's often what we do. You know, surgeons got really excited around the turn of the 20th century and just figured the best way to heal everybody is to just like take out the thing that's the problem. All right. But, you know, I'm a conservative person. I think we can keep as much as we can, maybe try these other therapies. But again, if all these other therapies do not work, we may need to take it out. Now, also, if we have a thymoma, which implies that there's a tumor in the thymus, we might take that out because maybe that is the cause of the myasthenia gravis response. All right, how do we rescue a patient who is experiencing a rough exacerbation? We give them plasmapheresis, where we basically, what's plasmapheresis? Anybody know? It's pretty dramatic. Plasmapheresis. It's pretty dramatic. It's kind of like dialysis, where you're taking all of the blood products, plasma, everything out of the body and cleaning it and then putting it back in. Okay. It's kind of like ECMO and dialysis a little bit. It's a way of like cleansing the blood. All right. IVIG is a type of immunoglobulin, which is really like at the very highest of treatment, very expensive, highest of treatment therapies for autoimmune diseases is to give them IVIG, which is IV or intravenous immunoglobulin, which is like monoclonal, like antibodies. They're just very cleaned antibodies that are going to help heal the person. It's very expensive, and that's why it's a rescue drug when a patient's experiencing a really bad exacerbation. Airway protection is important because remember, whenever you have these neuron or neuromuscular problems, neurons stop at the muscular joint junction. Muscarinic is a clue, right? That means the neuron touches the muscle to stimulate it to do something, right? But when you have MG or myasthenia gravis, it's not functioning correctly. So we want to think about the airway in case it's the diaphragm today that's not working the way it should. All right, so myasthenic crisis is something that happens when you take too little of the medication for myasthenia gravis, right? Or the illness itself, MG, can create a crisis, right? Which is why we need these exacerbation drugs. So when a patient with MG has a crisis, it's because they have too little of the medication and it's not effectively at a therapeutic dose, or they're experiencing exacerbation of the illness that's causing the severe weakness and the respiratory failure, okay, because the muscle of breathing is not doing what it's supposed to do. And then you'll get a patient that's dry. I know secretion implies that there's something wet there, but the secretions are dry mucous membranes. All right, so they may need more support if they're in myasthenia crisis. Whereas a cholinergic crisis is when you overdose on the medication for myasthenia gravis. All right, so again, we're really having to have tight management of the drugs for the people who have too little of the medication causing a problem and too much of the medication causing a problem. All right, so when you have too much of the muscarinic treatment or the medication for MG, okay, you will see these wet, when the muscarinic muscles have excess or too much, they're wet response, sweating, meiosis, diarrhea, bronchorrhea. All right, all of those are wet. Okay, I like to think of it like that. Whereas dry secretions are associated with too little, all right, underdosed or too little of the muscarinic receptor response. Okay, so when we stimulate the muscarinic receptors, we get sweating, diarrhea, all of this, tears. All right. So what do we do as nurses? We are going to support that patient's airway because nothing is more important than airway. If you ever have a question where it's asking you what's the first thing you want to do or what's the priority thing you want to do in a patient with this, support the airway. All right. If you any kind of neuromuscular problem, think of the airway because neuromuscular implies the diaphragm, right? Comes straight from the brain, one long nerve that touches the diaphragm and stimulates it to autonomically go up and down in accordance with our breathing. Okay, so support the airway because that's one of the most important muscles. All right, and we stop this medication if we go into cholinergic crisis. And we know we're in cholinergic crisis if we're sweating, meiosis, diarrhea, bronchorrhea, and some of the others, too many tears, wet. Okay, and what do? We give them the most drying drug you can take, atropine. Atropine actually is a naturally occurring substance in our botanical pharmacology. I think it's called belladonna. It's a herb that you can take, and they've isolated the actual active ingredient, which is atropine, which will dry you up right away. Okay. All right. Safety pearls will be around avoid using medications that make things worse for the patient with myasthenia gravis. So that would be aminoglycosides. Remember before when I told you about those antibiotics and anti-infectives? They don't like to play well with others, okay? So fluoroquinolones, macrolides, aminoglycosides are all problematic, okay? So you get a patient with myasthenia gravis who goes septic. We have to think about the anti-infective we will give them. Magnesium does not work well either. Magnesium must bind or bind to the medications for myasthenia gravis, thus causing them to not work or make things worse. Beta blockers, don't want to do it. Some anesthetics, no Botox. If you have myasthenia gravis, it makes sense, right? When you think about what Botox does versus what's happening in myasthenia gravis with muscle control, all right? And Botox is really just taking advantage of a toxin that causes the rigidity in muscles, okay? So we don't want to worsen or extenuate or be an agonist to that. All right, we're going to do a swallow screening on this patient when they come in. We're going to want to know how well they are able to swallow. We're going to want to know if we need to put them on aspiration precautions because they did not pass the swallow test. Okay, so any patient with myasthenia gravis may be doing a swallow test. Scheduling the meals the medications before the meals, because remember, if they don't have good muscle control, they might have dysphagia and thus might choke. Okay, so we want to give them the medication that helps release and improve muscle movement prior to 30 minutes prior to the meal. All right, and if you see those symptoms around choking, dysphagia, you may want to set up suction for your patients so that you can come in and help them out every once in a while by allowing them to use the suction. All right, fall risk, of course, any of these neuromuscular issues are a fall risk. And fatigue management, MG equals fatigue, right? You're working with someone who might have varying intermittent episodes of the worst fatigue you've ever seen. So believe them and then help them to manage their fatigue. All right, teach them how to conserve their energy. All right, so these are the summary. This is a summary, and I have another little quick summary around what we've talked about today. So Parkinson's is all about dopamine. So if we can address the dopamine precursor and improve or increase the amount of dopamine available, we're doing that with levodopa. All right, we also have dopamine agonists such as pramipexole and ropinirole that will also help us by hitting those D2 and D3 receptors get more dopamine. Okay. MAOB inhibitors like selegiline are also part of the Parkinson's treatment therapy, but we don't want to mix them with all those other drugs, and we really want to think about tyramine-containing foods when we go for those. The anticholinergics are big-time drugs, okay? They are serious drugs in that they are going to have an impact on the patient's dyskinesias. They possibly could have a connection with the patient's, when I think about Parkinson's and anticholinergics, I'm usually thinking about how they're going to treat their involuntary muscle movements. All right, Alzheimer's disease, the cholinesterase inhibitors, the main one here is donepezil, but there's also rivastigmine. The tigmines are therapies that usually are adjuvant therapies along with the donepezil. All right, and there's also memantine, which is an NMDA antagonist, works in a different profile from the cholinesterase inhibitors, but they all work to try to treat our populations of Alzheimer's patients. Not a lot that we can do for them. All right, it's a progressive disease. Multiple sclerosis, we have the interferons, glatiramer. I think I've also mentioned the orals, the monoclonal antibodies as well for multiple sclerosis. And I didn't add MG in here, but we just finished MG.